This is Selma Schimmel in Chicago for the group room. We're at the 2012 Multidisciplinary Symposium in Thoracic Oncology, which is brought to you by ASTRO, IASLC, ASCO, and the University of Chicago. We're joined by Dr. Elizabeth Nichols, resident in the Department of Radiation Oncology at the University of Maryland, Marlene and Stewart Greenbaum Cancer Center in Baltimore. And we're going to talk about how marital status and race influence survival in stage 3 non-small cell lung cancer patients. So hello to you, Dr. Nichols.
Hi, thank you for having me.
So how does a radiation oncologist take such a particular interest in this clinical but very psychosocial study as well?
I mean, one of the things that's important for radiation oncology is the fact that patients are coming in on a day in and day out basis for usually a 6 to 7 week time period. And when you have any patient that's supposed to be coming to your office every day, Monday through Friday for that time period, you become intricately involved in their social, emotional, family issues, because a lot of patients have issues with getting to their treatment every day. There's a lot of issues with them getting chemotherapy on a weekly basis at that time as well. So we actually find that that impacts actually patients getting through their treatment in a very significant way, and so that's something that became of interest to me as I was treating these patients.
So tell me more, because I find it fascinating. And there's a lot of single people out there, so yes. I don't want to scare anyone, but let's talk about what your patients actually reveal to you.
We would see on a daily basis that the patients who had a spouse or even just a caregiver, someone who they lived with on a daily basis, more able to come to their treatments on a more regular schedule. They're able to complete their treatments typically in the appropriate time frame, whereas patients who didn't have any support at home, transportation is often a lot more of an issue. Additionally, in these patients, because they're usually getting chemotherapy on a weekly basis, they tend to have a lot more side effects than patients with, say, stage 1 lung cancer. Typically, it's not at the beginning of the treatment, it's more towards the end, and we often find in those patients that having a caregiver or a spouse come with them to all of their appointments, we actually find out more about how the patients are actually doing than what the patient would actually tell you themselves.
Do you think that your research is totally unique to lung cancer, or would it not be applicable really across any cancer type, that if you're alone and isolated and going through radiation therapy, that many of the same issues would apply no matter what cancer you're dealing with?
Right. So the answer to your question is that it actually has been shown in other cancer types that this marital status does play an important role in cancer outcomes. It's been shown in head and neck cancers as well as prostate cancer as well. And I think ultimately it will be applicable to most other cancer sites, especially ones that have a known link to social behaviors like smoking, alcohol use, and so forth. So we weren't surprised by our findings with this study from that. But again, it just highlights the need for possibly trying to provide more social interventions for our patients.
And it would seem to me in some way it's a matter of semantics, because is it marital status or is it just really relationship and support status?
Right, right. Yeah, in our study, we allowed patients to self-identify whether they were married or single. It wasn't based on any legal documents, and at least in our patient population, a lot of patients who have someone that they've lived with for a long time will call themselves married. But that's definitely something that I think needs further clarification, and because our study was done retrospectively, that's kind of the only way we could determine those types of things. But I think going forward, we'd like to kind of collect that data prospectively and see, is someone living with someone? Is it a family member or a friend? Is it a spouse or a daughter, and so forth?
What about patients who then get into a support group or some kind of supportive setting, or refer to an oncology social worker or an oncology nurse for further assistance? What did you learn about those aspects of support?
We provide all of our patients with those types of support as well, whether they do or don't have a caregiver who's with them all the time. And I think those interventions do help to a degree, but we would venture to say, based on what we've seen in our patient population, that it's really having kind of the same person there on a day in and day out basis. Because even our patients who have, say, a different friend with them every week, it's again kind of seeing them on the day-to-day basis over that time period that I think really helps out the patients a lot. So I think those interventions do help, but I think we need to do I'd like to do more to provide for our patients because I think it can really help improve their outcomes.
Your study also looked at race.
Mm-hmm.
And what role does race and ethnicity have in lung cancer?
At this point in time, I don't know that we can really say that a certain race necessarily does better with lung cancer than other races. Unlike, for example, head and neck cancer, where we found that that was actually the disparities and that was actually associated with the HPV virus. In lung cancer to date, we don't really have any information that really says that a certain race does better than the other. But I think one thing that we're actually interested in looking at based on our results is if socioeconomic status is also impacting race, which is then in turn impacting overall survival. We hypothesize, at least in our community in Baltimore City, that that may be something that we're seeing, and that also again plays into access to care and those other sorts of healthcare policy mechanisms.
So where do you go from here with your research?
So at this point in time, we want to continue to validate our research on a larger patient set, which we're currently in the process of doing. From there, we also want to validate it based on socioeconomic status and look at, are the differences that we're seeing in race actually due to race alone or socioeconomic status as well. And we're doing that by coding for zip code for where patients live at the time of their treatment. And then eventually we'd also like to apply for funding to provide some sort of support system to our patients and see if that actually does impact their overall survival.
The solitary nature of cancer, no matter how many people you have around you, it's a very silent journey.
It is.
And the cancer patient is alone.
Mm-hmm.
The loved ones are on the flip side, and they're going through the journey too.
Right.
But they're not going through the physical trauma.
Mm-hmm.
So if it's that difficult on a cancer patient who has a good support system, it's chilling to really think about how isolating, and you use the word how stoic patients can be when you have nobody.
Yes, definitely.
Thank you for just driving home the fact that cancer patients need real support, and patients with challenging diseases like stage 3 lung cancer need particular support. Getting through that treatment is hard, but it can be made easier with love and support and empathy. Yep. Thank you very much, Dr. Elizabeth Nichols, resident in the Department of Radiation Oncology at the University of Maryland, the Marlene and Stewart Greenbaum Cancer Center in Baltimore.
Thank you.